Okay, we are going to talk about coagulation modifier drugs. So first, we're going to do a quick overview of coagulation things. Okay, so coagulation, that is the process of clot formation. Okay, so that's when we're forming a clot, that's coagulation. Thrombus versus embolus. So thrombus is a stationary clot, whereas a embolus is a moving clot. So tissue plasminogen activator, this dissolves clots. And it's actually something that our body creates. So clots don't just stay in our body, they actually get dissolved as well. And we'll talk about that in just a little bit. So the coagulation cascade, that is the coagulation process, is called the coagulation cascade. There are two pathways. You have the extrinsic pathway, which is initiated by external injury. Okay. So it would be like, if you got hurt, like a wound, or you had a trauma happen to you, that would be extrinsic pathway. Then you have intrinsic pathway, and that is an internal injury inside your body. And so damage to inside of your body, that would set off or initiate your intrinsic pathway. Medications that we're going to be studying about that alter coagulation, anticoagulants, these delay the coagulation process. Okay, so that's one thing that we're going to talk about first. So these things, these anticoagulants are going to either inhibit production of factors or they're going to bind factors so they can't be used. And we'll talk more about that in a little bit. Antiplatelet drugs, these inhibit platelet aggregation. Aggregation means grouping together, or so it inhibits platelets from grouping together, or it's going to prevent platelet stimulation. Okay, when platelets get stimulated, they release all this chemicals that do certain things, which we're going to see in just a little bit, and which actually attracts more platelets and causes all kinds of clot forming process. So antiplatelet drugs are either going to inhibit platelet aggregation or they're going to inhibit platelet stimulation. Now your thrombolytic drugs, these are going to break down clots. So it breaks down clots. These are going to break down clots that are already formed. So they don't prevent clots. They break down clots that your body's already formed. Okay. Hence the name thrombolytic. Thrombo meaning thrombus, which is clot, and then lytic, to break apart. So it literally defines itself. Antifibrinolytic drugs, these are going to promote coagulation. So sometimes when someone's bleeding out, etc., like especially surgeries, they may use antifibrinolytic drugs to help form clots quicker. Okay, so that's when we use it. Okay, so first thing we're going to talk about is anticoagulants. Okay, and in order to understand anticoagulants, we must understand the coagulation process, known as the coagulation cascade. So we're going to start off with a vessel. So this is the inside of your vessel, and it's one layer thick. Okay, so it looks just like that, one layer cell thick. So it's really thin. Okay, so you have your vessel, and then you have damage to your vessel. Okay, when you have damage to your vessel, it exposes the collagen underneath. That causes it to open up. Okay, so that's open up. Okay, so we've damaged the collagen, right? It's being damaged. So this causes platelets to stick together, which we said is called aggregate. So platelets aggregate. So we have all these little platelets aggregating right here. Okay. And what that does is once they aggregate, it causes them to release chemicals. Okay. So the platelets are going to start releasing ADP, which is adenine diphosphate. adenosine diphosphate, not to be confused with adenosine triphosphate, but it is similar. ADP and ATP are similar things, but ADP, okay? Thrombin, thromboxane A, and prostaglandin, okay? So the platelets release these chemicals, and these chemicals work to attract more platelets to the site of injury, causes vasoconstriction. So attracting more platelets to the site of injury is going to create a better barrier so that more blood isn't leaking out, right? We want to keep our blood. And then causing that vasoconstriction, again, to stop the bleeding and the leaking of our red blood cells. It's lastly going to stimulate the coagulation cascade, okay? So the platelets are responsible for stimulating the coagulation cascade. Okay, so they play a really important role with that. Okay, so let's talk about the coagulation cascade. So the coagulation cascade has two pathways. So it looks like a Y here. Okay, so the first pathway is intrinsic pathway, and we talked about this briefly, right? And the extrinsic pathway. So our intrinsic pathway, this is initiated with internal injury, whereas your extrinsic pathway is initiated with external injury. Okay, so what happens? We'll start with intrinsic pathway first. We have damage to a vessel wall, okay? So that damage to the vessel wall, what that does is it stimulates activation of factor 12, okay? So 12 by itself is just hanging out. It gets activated. That's what the A means, okay? So activates factor 12. When factor 12 gets activated, it then finds factor 11 and it activates factor 11. Activated factor 11 finds factor 9 and activates it. Activated 9 finds 8. I know this isn't in order. And it activates 8. 8 then finds 10 and activates it. Okay. So we have 10A. 10A, or activated 10, will find factor 5 and activate it. Activated factor 5 will find factor 2 and activate it. Factor 2A, so activated factor 2 is called thrombin, which is important later on. Thrombin then activates factor 1, which is called fibrinogen. Okay, now we're starting to get into the clotting process. Okay, fibrinogen, when it gets activated, becomes 1A, which is fibrin. Okay, fibrin turns into fibrin strands. These fibrin strands, along with factor 13, they form a net-like structure that hardens and traps platelets, that forms a fibrin mesh. A fibrin mesh is considered a stable clot. Okay, so now we formed a stable clot. This allows for tissue repair. Okay, so now all the tissue underneath where that trauma was, whatever, it can now repair without blood leaking everywhere, right? During this tissue repair, your body starts making tissue plasminogen activator. This is also known as TPA. Okay, and what TPA does is it will go back to this clot and it will start breaking up the clot. okay? Because you can't keep the clot in there forever, right? You just want it in there long enough to repair the tissue that's underneath, and then your body's going to break it up. Now, for initiation of the extrinsic pathway, there's an external injury, just like before. So you have like a trauma or something like that, and that stimulates tissue factor, which then stimulates factor 3, okay, and activates factor 3. So factor 3, activated factor 3 is going to look for 7, factor 7. Factor 7 gets activated. Activated factor 7 activates factor 10. So you notice that both of the pathways, whether it's intrinsic or extrinsic, ends up at factor 10. So this area right here is called the common pathway because it's where both of them end up being, okay? So this is the coagulation cascade. This is how our body forms a clot, whether it's an internal injury or an external injury. It ends up at the same point, okay? So where do all these factors come from? I'm glad you asked. They actually come from the liver, okay? The liver makes these factors. And so what it does is it will it spits out these factors, and it'll spit them out into circulation for when they need them, okay? So they're just hanging out until circulation needs them. But the liver requires vitamin K to make some of its factors, okay? So it will get vitamin K from the GI system. It will use that vitamin K to make other factors, okay? These are going to be the ones in purple. So it makes all these factors. And these factors are considered vitamin K dependent factors, okay? And that will be really important shortly. So don't forget about that. Okay, so the first anticoagulant we're going to talk about is warfarin, okay? So we're going to use our two diagrams. We have our liver making the factors, and we have our intrinsic, extrinsic pathway, so our coagulation cascade. And now we're ready to see how this stuff works, okay? So first, warfarin is going to inhibit the synthesis of vitamin K in the GI tract. So that's really significant. That's the only thing warfarin does, is it inhibits synthesis of vitamin K in the GI tract. Why is that important? Well, because the liver needs vitamin K to produce certain factors, right? So if we have a decrease in vitamin K from the GI, then the liver cannot make a bunch of these purple factors, right? That are vitamin K dependent factors, okay? So our vitamin K dependent factors, so we have a decrease in the amount of vitamin K dependent factors that the liver can produce. These factors are 2, 7, 9, and 10. Now I have them written as like normal letters. Normally when you see factors written out, they're written out as Roman numerals. But I think it's just easier to understand if you have them in just normal letters. So I just put them in normal, or numbers. I just put them in normal numbers. But if you see them, they're going to be, they always have factors as a Roman numeral. Okay, just FYI. All right, so if we know there's going to be a decrease in vitamin K dependent factors, okay, so there's going to be a decrease in 2, a decrease in 7, a decrease in 9, and a decrease in 10. So what that's going to mean is that when 3A up here, activated 3A, when it is trying to find 7, there's going to be a delay, right? Because there's going to be decreased amount of factor 7 that's hanging out in the blood, okay? So in that respect, it delays the coagulation process because activated 3A is going to have a hard time, or a longer time, to find factor 7 than it normally would, okay? Now, because it affects the extrinsic pathway, to measure how quickly the extrinsic pathway is coagulating, we use prothrombin time, okay, or PT, okay? So prothrombin time measures the clotting time of the extrinsic pathway. Because it measures the clotting time of the extrinsic pathway, we use PT to determine how much effect warfarin is having on the body, on the clotting process. Because we know that warfarin affects the extrinsic pathway. So we know that because it affects that pathway, we can measure that pathway, see how quickly it's clotting, and that will let us know how much effect warfarin is having. Okay. So a normal PT is 11 to 13 seconds. So the minute this gets activated, the minute factor 3 gets activated, the time starts, okay? So it only takes 11 to 13 seconds to reach a thrombin, okay, down here, okay, to start forming that clot, okay? So that's super quick. Therapeutic. So there are some situations when we don't want them to clot so quick. And we'll talk about reasons why we don't want them to clot so quick in a minute. So when we want to delay the clotting process, we call that therapeutic. So therapeutic PT time is 18 to 24 seconds. So we just want to delay the coagulation process just a little bit longer. Okay. Again, we'll talk about why we want to do this in a little bit. But so therapeutic means we're delaying the coagulation process on purpose, okay? Because generally someone's at risk for forming clots quickly or whatever, and we'll talk about that. Okay, so there's another thing besides PT that we can use to determine clotting time, okay? And that is international normalized ratio, okay? So what this is it's just a ratio of the patient's PT over the normal PT, okay? So, so we would take, say the patient's PT was 20 and a normal PT is 13. So we would divide, so 20 divided by 13, and that would give us an INR. A little bit easier to understand in a second. So if we have therapeutic, okay, so a normal INR, so our INR, if we're not on any kind of anticoagulant or anything, a normal INR is around 1, okay, which means it takes us the same amount of time it takes any other person to form a clot, okay? Therapeutic INR is around 2 to 3. So what 2 to 3 says is it takes that person 2 to 3 times longer to form a clot than the average person, than the normal prothrombin time, okay? So INR is really easy because it tells you really quickly how much quicker or how much longer their clotting time is, as opposed to being like, okay, well, how many seconds is the PT supposed to be, and how many seconds are they now? You know, so it's a little bit easier to remember. Oh, INR, that's really easy. I know if there are 2, then they take 2 times as long as the normal person to clot. If there are 3, it takes them 3 times longer than the normal person to clot. You know, so it's a really easy way to see how they're doing. Whether they draw an INR or a PT is just really just dependent on the physician or the prescriber. Okay. So it just depends. Some of them want both of them, both numbers. Some of them want just the INR. So it just totally depends on the person. So to go back to the fact that warfarin inhibits synthesis of vitamin K in the GI tract, it is dose dependent. So if we use more warfarin, if we give more warfarin, we're going to have a further decrease in the amount of vitamin K dependent factors available. The more warfarin we use, the less the liver is going to be producing those vitamin K dependent factors. So in general, what we do is we start out with a basic dose. We let it get into their system in a steady state. Warfarin takes a very long time, about a week, to get a steady state because it has a very long half-life. And so we will give them a few weeks take their do their blood work and find out what their INR is, find out what their PT is, and see, do we need to increase that dose? Do we need to decrease that dose? Because people act differently to different drugs, and there's a lot of things that work on warfarin that will like certain things that we eat are going to affect how effective warfarin is and stuff. So it depends on the patient's diet, etc. So the first, 2 or 3 months that they're on warfarin, we're going to be drawing their labs until we get their dose right, till we get it exactly the way we want it. Okay. Now, the next thing we're going to be talking about is heparin. Okay, remember this coagulation cascade. Okay, so we're going to use it again. Okay, so heparin binds activated factors, certain activated factors 2A, 9A, and 10A. Okay, so that's going to affect 2A right here, and 9A, and 10A. Okay, so bound factor 9A causes a delay, okay, in activating factor 8, okay? So there's the delay process, okay? Now, you'll notice that heparin only affects the intrinsic pathway, okay? Remember, warfarin affected extrinsic pathway and intrinsic, but we use extrinsic to determine how warfarin is affecting the coagulation cascade. With heparin, it only affects the intrinsic pathway. So we look at activated partial thromboplastin time, which is abbreviated APTT or PTT. So a PTT measures intrinsic pathway coagulation time, okay? So since we know that heparin affects the intrinsic pathway, we will use a PTT to see how much effect heparin is having on the coagulation cascade, okay? So a normal PTT is around 30 to 40 seconds. So it's significantly longer than the extrinsic pathway. And that is because it has like twice as many steps to get to the common pathway as the extrinsic pathway. So it's much longer. Remember, extrinsic pathway was like 11 to 13 seconds. So this is significantly longer. So therapeutic for a PTT, what we'd like it to be, is 60 to 40 seconds. So about twice of what normal is, which is pretty easy to remember. Okay. So just like with warfarin, the more, warfarin we used, the more or the less factors that were produced. With heparin, the more heparin we use, the more binding that happens. So it's also dose dependent as well. So the more we use, the more it's going to affect the coagulation cascade. Okay. So why do we even want to delay coagulation? Well, the purpose is prevention and treatment of clots. So it does not dissolve clots, okay? If you look at this, remember the only thing that dissolves clots is our tissue plasminogen activator, okay? What it does, what the anticoagulants do is they will prevent clots from getting bigger and dislodging. It also allows the body to dissolve it on its own with its own TPA, that kind of stuff. So that's how it treats clots. So prevention, it prevents it from even forming to begin with. And then the way it treats it is just preventing it from getting bigger and allows the body to process the clot on its own using its own TPA. So indications, It takes 1 minute to circulate 5 liters of blood around your body. Okay. So that is that is very quick, right? It's very fast. In fact, it is around 3 to 4 miles per hour, which is kind of crazy. So any condition where blood may be slowed or pulled, okay, is going to increase your chance of forming a clot. Because remember, especially with the extrinsic pathway, it only takes 11 to 13 seconds for it to start forming a clot, right? That's pretty quick. So it doesn't need to slow all that much, okay? So, yeah, so just remember this. So, because it takes 11 to 13 seconds here on this side and 30 to 40 seconds on the intrinsic side, okay, just to form a clot. So things that could potentially cause you to have slowing or pulling of your blood is prolonged sitting and bed rest, okay, an MI, okay, myocardial infarction. If you have unstable angina, you have DVTs, irregular rhythm like atrial fib, okay, that can definitely cause, because with atrial fib, your atria kind of quiver a little bit before you have your QRS complex. And that quivering, if it takes long enough, can start forming a clot because blood is sitting there. Okay. It's not going anywhere. Can be with valves, stents, pacemakers, etc. Anything that's abnormal in the body in that normally nice, smooth section. Okay. Not so your vascularity should be nice and smooth. Okay. So if anything makes it irregular, that's the potential for blood to be pulled there or to be slowed down. So indwelling devices, absolutely. Okay. Or if you have an embolism. Okay. Because normally, like I said, your vessels are nice and smooth. And so it allows for nice and smooth blood flow, like this right here. Okay. But when you have an indwelling device, okay, like right here or here or here, okay, it makes irregularities in the structure of your heart and disrupts blood flow, which is going to cause your blood to slow down or pool, which increases your risk for forming a clot. Okay. Now, the first anticoagulant we're going to talk about is heparin. So, heparin is given sub-Q or IV. Its mechanism of action, we talked about already. So, it binds activated factors 2A, 9A, and 10A. So, those right there. Okay. Evaluation of effectiveness. So, we're going to measure the APTT, right? Because it tells us how quickly the intrinsic pathway forms a clot, okay? So therapeutic for lab, we want a APTT of around 60 to 80 seconds. Remember, a normal PTT is 30 to 40 seconds. So a therapeutic PTT is 60 to 80 seconds. Okay. Our goal is have no development or no further development of a thrombi. Okay. Adverse effects, hemorrhaging. Okay. That'd be too much heparin, right? If we're hemorrhaging, then too much heparin. Heparin can also cause heparin-induced thrombocytopenia. This is a sudden or gradual drop in platelets. It's usually when your platelets are less than 1,000, they get down to that. And if you've had it before, then you're prone to having it. So it's not recommended that you would get heparin again. Because heparin-induced thrombocytopenia happens, this is why we only use heparin flushes on central lines. We don't use them on peripheral lines because we don't want to expose the body to heparin more than it needs to be. Okay. Hypersensitivity reaction. If you have a hypersensitivity reaction to heparin, it would give you chills, fever, urticaria. So you do want to give a test dose to make sure that they're doing all right. Okay. they're handling it all right. The antidote for heparin, very important, is protamine sulfate. What protamine sulfate does is it binds heparin. Okay. So if you bind the heparin, then it can't do what it's supposed to do, right? It's like it puts it in jail so it can't do its job. Its job is binding those activated factors, right? Okay, so contraindications with IM injection. You don't want to give an IM injection of heparin because it could cause large hematomas. You're going to give it sub-Q or IV only. Contraindications would also be if they already have thrombocytopenia, and that would be platelets less than 100,000. Okay, so if they already have thrombocytopenia, you do not want to give heparin. You do not want to give them during or following surgeries of the brain, spinal cord, lumbar puncture, regional anesthesia, because it can cause a spinal or epidural hematoma. Okay, so won't want to do that. Want to use caution with patients who have hemophilia. Hemophilia is when they're born genetically missing the recipe per se of making one of the factors. So they're usually factor 8. So they're missing one of the factors, thus it stops the coagulation process, right? So they have to get regular infusions of this factor in order to clot properly. If they have a dissecting aneurysm, peptic ulcer disease, severe hypertension, hepatic or renal disease, because remember that the liver makes these factors, right? So if we have a problem with our liver, that means we're going to have a problem making those factors. So any kind of hepatic disease is a big problem. Renal, what is your renal responsible? Your kidneys responsible for? Erythropoietin, right? Which is going to stimulate red blood cell production by the bone marrow. It also protects the red blood cells from destruction. So very important in the blood process, right? So if you have any kind of issues with your kidneys or your liver, you want to be really careful with either one of those. And with threatened abortion. So basically anything that's going to increase your risk of bleeding, okay? You're going to use caution with that. Interactions, aspirin and NSAIDs, they also inhibit platelet aggregation. So gonna affect the coagulation process as well. So do you really want to be taking 2 medications that's going to affect the coagulation process? I don't know. It depends on what's going on, right? But if you take 2 medications, 2 things are affecting the same thing, you're going to have twice as much action going on, right? And then alcohol delays coagulation. Okay, so not a good idea to mix that with anticoagulants, period. Okay. So our nursing considerations, we want to do a baseline and monitor vital signs, CBC, which is going to give us our platelets and our hemoglobin hematocrit. You want to give deep sub-Q, administer in units, okay, using a 25 or a 26 gauge needle, which is tiny, okay, for a reason, so that we don't cause bleeding at the site, okay, or we don't cause a hematoma at the site either, okay. Check with the dose with another nurse because there's multiple concentrations, okay. You want to make sure that you're using the right concentration, you're using the right dose, okay. You want to administer at least 2 inches from the umbilicus. Very important. Okay. You do not want to aspirate because that will cause bruising, or rub the site because, again, will cause tissue damage, okay, and bruising. So don't do that. You want to rotate sites. If you're giving IV, it's a continuous IV. You're going to use infusion pump. Okay, so you're going to use one of these. You're going to monitor the APTT every 4 to 6 hours until you reach a therapeutic dose. Now, the half-life of heparin is really short. I believe it is 4 hours. I think it's coming up, but it's short, so you can reach a steady state pretty quickly. You want to make sure you check doses with another nurse, especially if you're giving a continuous IV. Okay. with patient teaching, they need to monitor for indications of bleeding, okay? So bruising because of decreased clotting time. If they have bleeding gums, okay, when they're brushing their teeth, any abdominal pain that can be from abdominal bleeding, okay? If they have nosebleeds, okay, that could be because of a decreased ability to clot. Coffee ground emesis, this can be from bleeding in your stomach, again. Tarry stools, from bleeding in your lower GI area, okay? So they need to avoid using over-the-counter NSAIDs like ibuprofen, aspirin, or any meds containing salicylates, okay? It's better to use acetaminophen, okay? Because these are going to increase your risk of bleeding. So you would use acetaminophen. Although acetaminophen does have some anticoagulation effects with other medications. So we'll talk about that later. But for heparin, it's okay to use acetaminophen for pain control or fever control. They need to use an electric razor for shaving. They need to brush their teeth with a soft toothbrush because both of these are going to help decrease the risk of bleeding. Okay. All right, so now we're going to talk about another anticoagulant that's an injectable. This is a sub-Q, enoxaparin and fondaparinux, okay? Now, enoxaparin is the main one that we're going to talk about. That is Lovenox. You guys give this all the time in the hospital. So its generic name is enoxaparin. So the mechanism of action is that it inactivates factors. So it's going to delay coagulation process. Now, enoxaparin is low molecular weight heparin, okay? So it's a synthetic form of heparin. It's a smaller molecular structure. So it works similarly to heparin. It does bind to 9A, but mostly, oh, I got those, sorry. Mostly it inactivates factor 10A, which is the most important part, because it mostly inactivates factor 10A. It makes it more predictable. So you don't have to draw labs on a patient that is on enoxaparin. You know, if they go home on it, you don't have to draw labs. They don't have to make sure it's therapeutic, okay? Because it's so predictable. With warfarin and with heparin, they affect so many different ones. And so it's unpredictable as to how their body's going to react. With enoxaparin, it's not really, because it's mostly 10A, we do not have to draw labs for that one, okay? Now, fondaparinux, it inactivates only activated factor 10A as well. So your adverse effects are from delayed coagulation. So often your adverse effects are going to be the overexpression of your mechanism of action. So our mechanism of action is to delay coagulation, right? Well, it can work a little too well, right? And cause hemorrhaging. So that'd be from where you have too much bleeding, right? From too much delay. Okay. So neurologic damage from spinal hematomas. So a spinal hematoma is bleeding within the vertebral canal causing bleeding, okay? So it'd be like just like that, blood right there, okay? So it causes compression and inflammation of the spinal cord because blood is in there where it's a very finite amount of space. And it can happen during spinal or epidural anesthesia. So that's why you're not going to give these during an LP or anything like that. Okay, a lumbar puncture. So fondaparinux. Okay, so anyway, sorry. So with during a spinal or epidural anesthesia, we need to make sure we monitor sensation and movement of the lower extremities, make sure that a hematoma isn't potentially happening. With fondaparinux, it has a black box warning that because of its high potential to cause spinal hematomas due to epidural cath, so you cannot use it. Okay, so really, really super important about that. Thrombocytopenia, you need to monitor, is a potential adverse effect. So you want to stop if the platelets are below 100,000. So we need to make sure that we're monitoring the patient's platelet count and make sure that it's not getting too low. So contraindications, IM injection, again, just like with heparin, if you give it IM injection, it's going to cause a large hematoma. So we don't want to do that. If they already have low platelet counts, thrombocytopenia, which again is platelets less than 100,000. We don't want to give it during or following surgeries of the brain, spinal cord, LP, or regional anesthesia, again, because it can cause bleeding within that space. So increases your risk of spinal or epidural hematoma, okay? Which again is that bleeding within that spinal cord, okay? Which causes complications, the compression and the inflammation of the spinal cord. You want to use caution with patients who have bleeding disorders like hemophilia, dissecting aneurysm, peptic ulcer disease, severe hypertension, hepatic or renal disease, and threatened abortion. Yes, these are the same as with heparin. So interactions, aspirin and NSAIDs, which inhibit platelet aggregation. Oh, okay, those increase, sorry. So use caution on anything that increases your risk of bleeding, for bleeding or bleeding, causes complications, okay? So aspirin or NSAIDs, they're going to inhibit in alcohol or interactions because they're going to inhibit platelet aggregation, which is going to delay coagulation. So evaluation of effectiveness, just like with heparin, no development or further development of thrombi or embolus. Antidote for enoxaparin only is protamine sulfate, and that's if there's a toxicity or overdose. And it's the same as heparin because enoxaparin is low molecular weight heparin. It is so similar to heparin that protamine sulfate will bind it as well. But of course, it will not work on fondaparinux, okay? Only on enoxaparin. Okay, so nursing considerations. Sub-Q injections use a 25 to 26 gauge needle. Again, really nice and small. And we're going to rotate sites. So these are the areas where you can, areas shaded in purple are the sites that you can give it. Want to make sure you're at least 2 inches away from the umbilicus. You do not want to expel this air bubble right here, okay? So, because that actually enables you to give all the medication because it ends up behind the medicine and kind of gives it that push, okay? You do not want to aspirate because it can cause tissue damage. You do not want to rub the site after injection because that will cause bruising, okay? You want to monitor for patient teaching, make sure they're monitoring for indications of bleeding, which we talked about. So bruising, bleeding gums, abdominal pain, the nosebleeds, coffee ground emesis, and tarry stools, okay? They need to avoid using over-the-counter NSAIDs, aspirins, and any meds containing salicylates. We want to use acetaminophen instead for any pain or for fever, because these will increase your risk of bleeding. So you want to use an electric razor for shaving. Brush teeth with a soft toothbrush. That will decrease your chance of bleeding. Just like with heparin, okay? Same kind of stuff. So you're going to see this frequently. All right, now we're going to move on to warfarin. So the mechanism of warfarin we talked about already. So it inhibits the synthesis of vitamin K, which decreases the amount of vitamin K dependent factors made, which is going to delay the coagulation process in these areas. Okay. So your adverse effects, hemorrhaging, right? So have some bleeding going on. Hepatitis, okay? Because hepatitis is a potential adverse effect, you want to monitor LFTs. Our liver function tests, those are AST and ALT. Okay. If they have toxicity or overdose, so that would be a lot of bleeding, okay? It can be cause hematuria, melena, bruising, bleeding gums, okay? So you want to make sure you're telling them to watch for that kind of thing. Melena is bleeding in like stool, okay? Bloody stools, okay? Hematuria, blood in your urine, okay? So first thing you're going to do is you're going to stop the warfarin. Now, if you just stop the warfarin, it can take 36 to 48 hours for the liver to start producing enough vitamin K dependent factors to actually start clotting, okay, to make a difference, which sometimes that's okay, okay? Depends on how high the INR is, okay? The antidote for warfarin is vitamin K. We're going to give PO vitamin K if they have an INR around 4 to 9. So just think about that. That's just for a patient who has 4 times to 9 times longer to form a clot. That is a long period of time, okay? So we do not give vitamin K until it's extremely long, okay? Even giving PO, okay, it can take 24 to 48 hours for the maximum effect of that PO vitamin K. Okay, so we've increased the time period. So we went from 36 to 48 hours on its own to speeding it up to maybe 24 hours, right? We can give IV vitamin K only when needed, only when we need a rapid decrease in our INR, okay? And for this, it can reverse the effects in 6 hours. Okay. But the only problem with that is that it can cause warfarin resistance for up to 7 days, which means that warfarin will be useless in that patient for a week. They can't use it. Like it's not going to do any good. Okay. So in that case, they're going to need to be on heparin or enoxaparin until the therapeutic, that time period is gone and it starts being non-resistant to warfarin and can start taking that back in. Now, IV vitamin K has a lot of risks, okay? There's a high risk of anaphylaxis. So we're going to give it in small doses and we're going to give it really slow, okay? Because the huge risk is overcorrection. Because if we have overcorrection, if we give too much vitamin K and we give it too quickly, then we can have clot formation, which will cause an MI or a stroke or, who knows. So we definitely don't want that to happen. Now, the half-life, I talked to you a little bit about this already. So warfarin has a very long half-life. It is 12 hours to 3 days. So, and it depends on the patient. So it can take around a week to reach a steady state and to get out of the bloodstream too. So often when patients are on warfarin in the hospital, or in the patients that are on warfarin, they come into the hospital, they're switched to heparin or they're switch to enoxaparin in case they need a procedure or surgery, because they need to get that warfarin out of their system, right? And so they put them on enoxaparin or heparin because it's much easier to just DC them the night before a surgery, because their half-life is significantly smaller. So the half-life of heparin is 60 to 90 minutes. Okay, so that's really quick. I told you it was quick. The enoxaparin half-life is 4 to 5 hours. So heparin guy, you could just DC that in a few hours and be ready for a procedure. Enoxaparin, you probably want to wait 24. You probably want to wait till the next day, because remember, to get out of your system, it needs about 5 steady state, 5 half-lives. Remember, to get out of your system. Okay, so 5 times 5 would be what, 25 hours. So 24 hours would be about right, right? Hopefully that wasn't too many rights in that conversation. Okay, so contraindications. It is pregnancy is a contraindication because it is a category X. Category X means that studies in animals or humans have demonstrated fetal abnormalities with it. So we definitely don't want to be giving that. It can cause, so contraindications is thrombocytopenia, which decrease in those platelets. Remember, less than 100,000 platelets. You don't want it during or following surgery of the brain or spinal cord, LP or regional anesthesia. Yes, this is the same as heparin and enoxaparin, so it should be easy to remember. Contraindications if they have vitamin K deficiencies, because that means the liver is already going to have a hard time forming those factors, so we don't want to cause even more issues. If they have a liver disorder, right, because the liver makes those factors, and with alcohol abuse, because alcohol is twofold. Alcohol decreases platelet aggregation, but it also puts stress on the liver. So if the liver's trying to detox your alcohol from your bloodstream, it can't also be turn around and be making these factors. So whenever alcohol is involved, it's taking up time and energy of the liver, so it can't do something else. And the liver does a lot of jobs. So when you add alcohol to the mix, or you add drugs that affect the liver, then that means the other jobs that it's used to doing are gonna pay. Okay, they're gonna not be as effective. So all of those things are going to decrease vitamin K dependent factors being made. So we're going to use caution with hemophilia, dissecting aneurysm, peptic ulcer disease, severe hypertension, and threatened abortion. Yes, these are the same as you saw in heparin and enoxaparin. Interactions. Things that increase the effects of warfarin, you have acetaminophen, aspirin, heparin, glucocorticoids, sulfonamides, and cephalosporins. Notice acetaminophen. We talked about before that, if you could take acetaminophen with heparin and enoxaparin. Well, acetaminophen with warfarin, you just have to be careful because it can increase the effects, okay? Things that decrease the effects of warfarin, you have phenobarbital, carbamazine, phenytoin, oral contraceptives, very important, and of course, vitamin K. The more vitamin K you eat, the less effective warfarin will be. Now, does that mean they cannot eat vitamin K containing foods? Absolutely not. They just need to be consistent in the amount of vitamin K that they're taking in, okay? So that whatever is normally in their diet, if they're consistent with that, then we can make their dose adequate with whatever consistent amount of vitamin K they're taking in. They don't need to suddenly change their diet to taking in a lot of kale, which has a lot of vitamin K in it. And if they go on a kale diet, then that's going to be a problem. We'll need to adjust their warfarin level for that. So nursing considerations, we need a baseline and monitor their vital signs, the CDC to see their platelets, hemoglobin, hematocrit, their PT, and their INR. Remember, we're measuring PT and INR because it is what measures the extrinsic pathway, which is affected by warfarin. Remember, we want our PT to be 18 to 24 seconds. That's therapeutic. and we want an INR around 2 to 3 seconds. Sorry. IV administration, you want to dilute it and give it over 30 minutes. So patient teaching, administer at the same time each day. Remember, because that's going to help us keep a consistent amount of warfarin in the blood. We want a nice steady state and just keep that steady state in there. Monitor their PT and or INR levels to make sure the dose is nice and therapeutic. Want to monitor for signs and symptoms of bleeding. Which would indicate that they are maybe taking too much. Avoid over-the-counter medications with NSAIDs like ibuprofen, salicylates like aspirin, and acetaminophen, because they are going to increase. Oh, and then avoid cranberry juice and alcohol, because all of those are going to increase the risk of bleeding. Okay. We want to avoid thrombi development. So these patients are at risk anyway, or they wouldn't be on this medication. So things that increase your risk of thrombus development would be wearing tight clothing, sitting for long periods of time. They shouldn't let their legs dangle. That's not good for them. Okay. Crossing their legs is not good. So to avoid development, to prevent thrombus from forming, they should wear no tight clothing. Don't sit for long periods of time. Elevate and move their legs when they're sitting, okay, so that their legs aren't dangling. They should wear a medical alert bracelet using electric razor. Use a soft toothbrush. They should have a no sitting thing. They should eat a consistent amount of foods high in vitamin K, okay, so it's consistent, okay. So things that are high in vitamin K is green leafy vegetables like kale or spinach. Other foods high in vitamin K are broccoli, canola oil, and soybean oil. I guess soybeans too, but it wasn't mentioned. Okay. Now, antiplatelet drugs, really antiplatelet drugs should be called platelet aggregate inhibitors, because they basically prevent platelets from coming and sticking together. So let's review just a little bit. Remember this picture, okay? So how the platelets get, you have damage to the vessel, and the platelets stick together. And then, so you have these platelets stick together, they release these chemicals. These chemicals here are going to cause more platelets to come to the site of injury. It's going to cause vasoconstriction, and it's going to cause stimulation of the coagulation cascade. Okay. So mechanism of action, all of these drugs are going to prevent platelet aggregation and or stimulation. Okay. So it's either going to work here with keeping them getting together, or it's going to work here with releasing these chemicals that really attracts more of them to the site. Okay. So salicylate, this aspirin, this aspirin is going to be your prototype for this one. And what it does is it decreases thromboxane. And what that does is going to decrease the vasoconstriction and cause platelet and prevent platelet aggregation. Okay. Your arterial vasodilators, the prototype for this one is pentoxifylline. These decrease the release of all the substances from the platelets, all of those up there. Your ADP inhibitors, clopidogrel is your prototype for this one. This is Plavix, by the way. I know y'all have heard of that one. What clopidogrel does is it decreases your ADP, which is going to decrease platelet aggregation. Lastly, your glycoprotein inhibitors. Abciximab is going to be your prototype for this one. And what it does is it decreases your platelet aggregation. Now, the interesting thing about abciximab, and this is, it's the abnormal one of all the group, It decreases platelet aggregation, but it doesn't decrease the amount of platelets formed. So it actually does not cause thrombocytopenia, which you're going to see these other ones do. So your abciximab is going to just have different, it's going to be the oddball of the whole group. Okay, so indications. Okay, so indications, we're going to prevention of a clot, right? So clots cause MIs, strokes, and TIAs. So we're trying to prevent all that, right? Some are used for intermittent claudication, which is, when you get muscle cramps or pain during exercise because you have a decrease in blood flow to the extremities from an occlusive artery disease of some sort. Okay. Some are used to help prevent clotting during cardiac procedures, like a cardiac cath or angioplasty or a stent placement, something like that. Your adverse effects are going to be, and this is for most of them, like I said, we have an oddball, but most of them are going to cause prolonged bleeding time and thrombocytopenia. Because they cause a prolonged bleeding time, we're going to monitor for bleeding. With thrombocytopenia, that's going to cause a decrease in platelets. So we're going to monitor our platelet count, okay? Aspirin specifically causes GI upset as well, can cause hemorrhagic stroke and tinnitus. Okay, so that's ringing in the ears and hearing loss. So we want to monitor for hearing loss, and we need to stop it if it occurs. Okay. Abciximab, remember this one's a little different. Okay. It can cause hypotension, bradycardia, bleeding from the cardiac cath site. So if we have that, we want to make sure that we're holding pressure at the site. You do that anyway, but you would hold it for a little bit longer if they're on abciximab. Clopidogrel causes GI upset. Pentoxifylline, this only causes GI upset. Oh, so I was wrong. It wasn't abciximab that causes pentoxifylline. That's the one that's the oddball. It only causes GI upset. It does not cause prolonged bleeding times. It does not cause thrombocytopenia. So it's the oddball of the bunch. Sorry about that. I made a mistake with that. Okay, so contraindications. So situations, basically it's going to be situations that put them at risk for bleeding disorders or bleeding would further increase their bleeding. They have coagulation issues at all. So contraindications, again, this is going to be for most. It's going to be these. You're going to have bleeding disorders or active bleeding, okay, because that would further increase the bleeding. If they already have thrombocytopenia, we're going to use caution with peptic ulcer disease, severe kidney or hepatic disorders. Remember, because your kidneys and your liver too, but your kidneys mostly makes that erythropoietin. So if you have a disorder, it's going to decrease the amount of erythropoietin that's produced. Thus, it's going to decrease the red blood cell production from the bone marrow, and it's going to take away that protective part of erythropoietin for the red blood cells as well. Aspirin, you do not want to give to children under 18 years old because of their risk of Reye syndrome. Reye syndrome is swelling in the brain and liver, can cause death. It commonly affects children recovering from a virus. It was thought only chickenpox, but chickenpox was a common thing back when this was found. And it was kids who had the virus or had a virus, and they were given aspirin to treat their symptoms. They think that maybe the aspirin triggered Reye syndrome from happening. Not sure, but definitely do not want to give aspirin to kids under 18 years old. You want to use caution with older adults. basically you have increase in bleeding with aspirin plus an increased risk of falls with older adults, and that's an accident waiting to happen. And also, I was just reading something in the National Institute of Health, and it was saying that in the older adults, like the over 75, that aspirin really did not affect their cardiac outcomes like it does to the younger folks. So aspirin may not be advantageous in the older population, which I thought was really interesting. Now with abciximab, contraindications are recent stroke, aneurysm, uncontrolled hypertension, and recent major surgery. Clopidogrel, intracranial bleed. I would think if you had any kind of bleed, that should be, pentoxifylline, only bleeding disorders. So pentoxifylline, again, is like the black sheep of the group. And so it doesn't have the contraindications like the others. It's only bleeding disorders, okay, retinal or cerebral bleeds. So interactions, other drugs that affect or enhance bleeding, examples would be like heparin and I think it's not working. There we go. Warfarin, heparin, or NSAIDs, okay? With aspirin interactions, it's quite a few, which is surprising because a lot of people that are on aspirin and they've had heart attacks, etc., and they have other cardiac stuff going on. But aspirin and beta blockers. So aspirin is going to decrease the antihypertensive effects of beta blockers. So we need to make sure that we're monitoring that blood pressure. Corticosteroids increase the GI effects, the GI upset of aspirin. So we want to make sure that we're watching for signs and symptoms of a GI bleed. And that would be like coffee ground MSS or black tarry stools. And then caffeine actually increases the absorption of aspirin, which is interesting because, you always see that you see caffeine plus aspirin plus acetaminophen, and that's the migraine medication, like Excedrin, I think. And so it's funny because the caffeine actually helps to increase absorption of aspirin. That's not the only reason caffeine's in there. Caffeine also causes vasoconstriction. So that's how it helps with migraines. But I just thought it was interesting that it increases absorption of aspirin as well. But because it increases aspirin absorption, it increases the risk of aspirin toxicity. And so just to remember, aspirin toxicity, actually, you haven't gotten there yet. Signs and symptoms of aspirin toxicity, that is tinnitus, hyperventilation, vomiting, and nausea. Okay, so make sure that they're aware of the signs and symptoms of aspirin toxicity. If they have any of this going on, they need to stop taking it. Okay, and let us know. Other interactions, clopidogrel. Oh, I messed up the PowerPoint. So clopidogrel is proton pump inhibitors will decrease the effectiveness of clopidogrel. So that's just supposed to be up there on that line, right there. Okay. All right, so patient teaching. So what are we going to teach them about aspirin? So they're going to take a low dose, which is 81 milligrams per day for stroke or MI prevention. Now, if they think they're having an MI, they need to take 325 milligrams of aspirin. They should always use enteric-coated tabs because that's going to help decrease the GI upset. They need to report any signs of stroke because remember, aspirin increases their risk for a hemorrhagic stroke. So they need to report any signs and symptoms of stroke. With ADP inhibitors or clopidogrel, they need to DC before surgery, but basically all of them should probably be DC before surgery. Arterial vasodilator, pentoxifylline, take with food. to help decrease that GI upset. They do not need to crush it or chew it. So it should not be crushed and put it in G, so to speak, kind of thing. Nursing considerations, bleeding times. We need to make sure that we're not delaying it too much. Monitor for signs and symptoms of bleeding. Monitor for adverse effects. With aspirin, there is an allergy, a cross-reactivity. If they're allergic to NSAIDs, it's highly likely that they're going to be allergic to aspirin. So there's that cross reactivity with other NSAIDs. Also, the potential for Reye syndrome. Remember, do not give to children under 18 years old. Super important. Clopidogrel. Remember, this is Plavix. They have the black box warning. Certain people may be unable to metabolize the medication to its active form, which will increase the risk for cardiovascular events, because then it's like they're not taking anything at all. Okay, so they even had that black box warning on Plavix because of that. Now we're going to talk about direct factor 10A inhibitors, so activated 10A, okay. Rivaroxaban is our prototype here. So mechanism of action, it directly inhibits factor 10A. So remember this, okay? So we're affecting this one right here. And so if we're inhibiting factor 10A, then that's going to slow coagulation. So indications, it's for DVTs, pulmonary embolus prophylaxis, and atrial fib. Adverse effects, bleeding, of course, because we're slowing coagulation. Elevated liver enzymes and bilirubin. So we want to make sure that we're checking our AST and ALT and our bilirubin levels, okay? Contraindications, if they have any active bleeding, severe kidney or liver impairment, again, because of their erythropoietin connection there, okay? You want to use caution with anticoagulants and any other antiplatelet medications, because that is going to increase your risk of bleeding. So our interactions, increased bleeding risk with these medications, with erythromycin, daltazizam, verapamil, quinidine, and amiodarone. Decreased levels of rivaroxaban is going to be rifampin, carbamazepine, phenytoin, and St. John's wort. Okay. Nursing considerations: monitor your hemoglobin hematocrit, your liver and your kidney functions. Okay, so our liver and our kidney functions, that's AST, ALT, and creatinine levels. Okay, BUN levels. Report any elevated levels to the provider. With patient teaching, administer the same time each day with or without food. So whatever it is, whatever they decide it's going to be, it needs to be consistent to help keep a steady state within the body, okay? But they can pick it, they can choose it. The only exception is if they are trying to prevent embolism or a stroke, they need to give it with the evening meal. I don't know why. I don't know why it matters. Seems like you should just say, okay, give it with the evening meal all the time, no matter what you're on it for. But anyway, so there it is. And then report any signs and symptoms of bleeding. Okay, now we're going to talk about direct thrombin inhibitors. Dabigatran is going to be your prototype medication for this, and that's Pradaxa, if y'all have heard of that one. The mechanism of action, it is going to directly inhibit thrombin, okay? So that is activated factor 2. So remember that right there, okay? Because of that, it's going to delay coagulation. So our adverse effects are bleeding. So we need to monitor for signs and symptoms of bleeding. And we want to check vital signs because usually vital signs will change as well if there's bleeding. GI upset, so we need to take with food, or you can take with a PPI or H2 antagonist. Contraindications, if they already have active bleeding going on, we're going to use caution if they have any liver or kidney impairment, again, because that will decrease the erythropoietin that's produced, and that affects red blood cells and bleeding. So interactions, things that increase the risk of bleeding are thrombolytics and anticoagulants. So obviously you have more than one medication affecting the coagulation cascade. It's going to have a additive effect, if not a synergistic effect, right? On the coagulation speed, right? Rifampin is going to decrease levels of the bigatran. Nursing considerations, you want to DC heparin and check a PTT before starting it, because heparin will also inactivate thrombin. Remember, 2A is one of the ones that inactivates. So we always want to make sure that heparin's out. We're not having two things doing the same thing. With patient teaching, want to make sure when they're given PO, you don't want to crush it or chew it. And the container must be used within 30 days. They have to throw away the rest of it if for whatever reason they have extra left over. Thrombolytic drugs, okay? The prototype, so thrombolytic drugs are drugs that break apart thrombus, okay? So the exact opposite of what we've been talking about. So this is when we have a clot that's already formed and we want to break it apart. The prototype for this one is alteplase, okay? We're going to use this if you have a thrombus or a clot that is significantly interfering with blood flow somewhere. The coagulation, okay, so just to review, remember, coagulation system forms a clot. So that's the part we've been talking about so far, this part right here. And then you have the fibrinolytic system, which is right here. And that is where the clot is formed and then the clot is broken up by the body, right? So let's take a closer look at this, okay? So you have a stable clot that's made that allows for tissue repair to happen. Your body makes tissue plasminogen activator on its own to break up this clot, right? In the body, it normally takes several days for this to happen, okay? For the tissue plasminogen to be activated and for all that to happen, because you want to give time for that tissue repair to happen, right? So with this drug, it is actually recombinant DNA created tissue plasmin activator. So we've created more tissue plasmin activator using recombinant DNA technology, okay? Because we use recombinant DNA technology, it is super expensive. So we make this and we give it to the patient, okay? So we're like giving them a boost of tissue plasmin activator. So it's fibrin clot specific because it only breaks up fibrin. That's its only job, okay? And it can break it up super quick, okay? Often we'll give it, and then we will give a flush of heparin right behind it to keep it open, because it has a really, really short half-life, like 2 minutes, I think. It's really short. 5 minutes. It has a 5-minute half-life. And so because it's so short, because we really don't want it acting for a long period of time, because we want it just dissolving the clot we want it to dissolve, not every clot in the body, because that would be really bad. You bleed out. So once we give the TPA, then we would flush behind it some heparin. Okay, so be specific to that. So adverse effects. Well, we're breaking up clots, right? So that's definitely going to cause some bleeding. It can induce Cardiac dysrhythmias, especially if there's a sudden change in the mean arterial pressure. So just imagine your vascularity is like a bunch of rivers and they're all connected together, right? And then you have a clog in one part of the river, and so it's backing up. Okay. All of a sudden, that clog is gone, right? So all of a sudden, there's this massive flow where there wasn't much of a flow before. That massive change in mean arterial pressure can induce cardiac dysrhythmias. So depending on how big the clot is, depending on where the clot is, it can potentially cause dysrhythmias by doing that. Interactions, increase bleeding if given with other drugs that also affect coagulation and platelet function. Contraindications, of course, concurrent use with other clot altering drugs, because it is extremely strong. It's extremely expensive. You want it to do just its job where exactly you want it to do its job, and then that's it. So it's actually a really dangerous drug. Okay, so more on alteplase. So your nursing considerations, close monitoring, because we are breaking up clots. Hopefully we're only breaking up the clot that we want to break up, but what are the chances, right? It's potential to get to other things and to break up clots that were forming for a good reason, and preventing bleeding. So close monitoring of your patients. You want to limit venipuncture injections. If you have to do any, you're going to hold the direct pressure for 30 minutes after you give them. You want pressure dressings to recent wounds, because they're going to start bleeding again, because we're potentially affecting the, we're breaking down that clot that they're forming, right? You want to monitor PT, PTT, H&H, your hemoglobin hematocrit, because you want to find out what effects it's having on the coagulation cascade, right? We can see how it's affecting both sides of the coagulation cascade by monitoring the PT, which is your extrinsic side, and your PTT, which is your intrinsic side. Monitor for changes in vital signs, level of consciousness, any kind of weakness, because a change in level of consciousness or weakness could be from hypovolemia, from blood loss. That would be really bad. You want to make sure that you notify your provider of any changes to any of these things, any labs, or to your assessment findings. You don't want to mix with other meds in the IV. You want to flush with heparin or give aspirin to decrease risk of rethrombus formation. Again, alteplase has a half-life of 5 minutes. So we flush with heparin to keep a new clot from forming where that one was occurring. And it occurred for a reason. So the things that made it happen may still be there, or the conditions that made it happen. We want to stop it if bleeding occurs, although it's so quick that I don't know, you could stop it. Administer with a proton pump inhibitor to prevent GI bleeding, okay? And to evaluate effectiveness of the medication, we should have lysis of the thrombus, right? We should have breaking up of the clot, which would restore circulation, because the thrombus is no longer blocking that blood flow, right? So that's our ultimate goal. And that is it. So please email me if you have any questions.